concept into the overall care of a patient. So, what are these psychosocial issues? So, first of all, for integrating psychosocial aspects into proper care, we have to understand what are the psychosocial aspects of a patient. So, psychosocial issues are challenges affecting psychological and social well being of a patient or an individual. So, it can arise from a disease impact or personal beliefs, family dynamics, social isolation, stigma, so and so. And especially in palliative care, they significantly influence quality of life and especially the end of life experiences of an individual. So, starting with the biopsychosocial model, we have to understand that many of our treatment methods are purely focused upon addressing the physical symptoms of a patient. So, apart from that, the theory was proposed by George Engel in 1977, and it proposed like it's a holistic approach to patient care, especially focusing upon the psychological and social aspects of a patient, along with the medical aspects of a patient. So it encourages to provide an integrated care by involving multidisciplinary team members, which means there can be different types of team members, especially professionals. So next one, we have to understand what is the concept of total pain. So we have explored that an individual will have multiple dimensions, especially in providing care. But we have to understand what pain actually is. So starting with the concept of total pain, it was proposed by the mother of modern palliative care, Cicely Saunders. And the concept of total pain includes addressing the physical, psychological, social, and spiritual suffering of a patient. So, not only the physical aspects, but we have to address their psychosocial and spiritual aspects too. So, it recognizes the multidimensional nature of suffering in palliative care. So, suffering is inevitable, but we can do our best to reduce this suffering. We don't have to promote the unwanted suffering among the patients. So, addressing this these psychosocial aspects will help a patient to eradicate their unwanted pain. So it demands compassionate, comprehensive assessment and management. So it needs a detailed assessment and it needs compassion to understand the situation they are in. And we need proper intervention or proper management to address these psychosocial issues. So here you can see the diagram of the concept of total pain. Uh, so here you are seeing the physical aspects of a patient, and the physical aspects are intertwined with the social and the spiritual aspects of a patient, as well as their psychological aspect. So it is overlapped with each other, as you can see. So this is the concept of total pain, where a patient's physical symptom is being addressed along with the social, spiritual, and psychological aspects of that individual. So, as I have mentioned, this concept was proposed by Dame Cicely Saunders, who is also considered as the modern mother of modern palliative care. So, here we are going to explore how we are assessing a patient to identify their needs and their psychosocial aspects. So this is the format we follow in Pallium India for addressing these kinds of needs. So starting with the patient overview, where we will address their socio-demographic details of a patient. Uh, Apart from that, we will address their no. We collect informations regarding their socio-demographic details, and we collect informations about the diagnosis, awareness about the diagnosis, chief complaints in which the patient is in, especially there will be some symptoms expressed by the patient. and the functional status of the patient, whether he is a bedbound patient or semi-ambulating or fully ambulating. So next we come to the insight to illness. So in this part, we are exploring the awareness of the patient and the family regarding the patient's diagnosis and prognosis. So they should have an idea. Actually, they should have an idea about the diagnosis and prognosis. In some cases, they won't be having it. So we have to explore it. Then only we will be able to communicate properly, and we will be able to rule out a proper treatment plan or care plan. So here we are assessing a patient's and family's understanding and acceptance of the patient's diagnosis and prognosis. So in next, we are going to explore what the family overview of a patient, especially in caregiver availability and the support system within the family and other aspects of internal resources. So we will understand more about this in the upcoming slides. Like we have to explore the genogram, then only we will be able to understand how to identify the internal resources within the family to identify the psychosocial aspects of care. So next one is social overview, especially focusing upon the social connections of a patient and isolation. Uh, how much they are isolated from the external community, and even if they are in a family where there are multiple members, they might feel socially isolated, they might not be having a proper relationship or a proper connection with the family members. So it is also an important factor to address. And the next one is economic overview. So in economic overview, we are going to explore the financial burden of the patient and in which status they are in. So they might be having a lot of financial resources within the family, or they will be receiving government services, or especially reimbursement supports, pension schemes, and all. So we have to identify their social resources, and we have to identify in which they are lacking in maintaining a proper social connection. So the next one is economic overview. The next one is psychological overview, where we are assessing a patient upon their mental health aspects. Especially, we have to note whether the patient is conscious oriented and the patient is in a position to take decisions for himself. So apart from that, we have to assess what kind of chief symptoms are being expressed by the patient. They might be lacking sleep. They might be having a kind of psychological distress, having anxiety, depressive symptoms, withdrawing from the social interaction and all. So we have to identify what kinds of psychological symptoms are being expressed by the patient. So the next one is spiritual overview. For understanding about the spiritual aspects of care, we have to divide that section into two. So, starting with the existential well being of a patient, especially related to their purpose of living, hope, joy, and whether they are able to enjoy something in their life, or recalling a moment of happiness in their life. So all these aspects are important to identify whether they are having a well-being in the existential aspects. So the next one is religious well-being. Both these are included within the spiritual overview itself, and some of these areas being overlapped with the psychological aspects too. So, in the spiritual aspects, the next one is religious well being. So, each of us are having our own religious ideas or beliefs, and we will be having a different kinds of unique perspective towards our own religion, or we might be having religious practices in our own way. So we have to explore what kind of religious faith or religious path is being followed by the patient. So this spiritual overview is explored, especially in the end of life care moments. So they might be having a need for reconciliation, or might be having spiritual doubts. So we have to channelize the spiritual resources from the community itself. So the next one is vulnerability assessment. Why we need to assess a patient's vulnerability? Because actually we are assessing the socio-economic vulnerability and psychological vulnerability of a patient, as well as their physical vulnerability too. So in psychosocial aspects, we are only assessing the socio-economic and their psychological vulnerability, dividing into mild, moderate, and severe. So if it's a case where it should be addressed on crisis intervention methods, so we'll be considering that case in severe. And if they are having some mild or moderate psychological symptoms, especially in lacking coping mechanisms or lacking struggling to cope up with their situation, current situation, especially after getting diagnosed with a serious illness. So we'll be referring that case as moderately vulnerable in psychological aspects. And in mild, we'll be considering the case as mild because they got diagnosed with an illness, so they might be having mild coping up issues or mild psychological distress and all. So we'll be considering the case in mild, moderate, and severe aspects of vulnerability in psychological and socioeconomic aspects. So here we are going to explore about the genogram. So I have already mentioned. One minute, please. So okay. So next we are going to explore what genogram is. Genogram is a pictorial representation of a family. So we have to explore their three generational families in order to identify their internal resources. So as you can see here, this is our patient who got diagnosed with the cerebral palsy, and he's 25 years old. So we are exploring his siblings, his father and mother, and his father's siblings, and his father's parents, which means his grandparents. So why we are addressing or why we are identifying these aspects means it's because we have to identify their internal resources and their support system. So here, as you can see, the mother got expired, and Arjun has a brother, and his father is an IPS officer. So it's an hypothetical case, okay? So, and his brother Raghav, Krishnan's brother Raghav is an IT employee and got divorced with a 38-year-old Soumya, who is also an IT employee. And they are having twin girls. Both of them are in plus one studies. Okay, and their grandparent, which means the patient's grandfather, was a chief secretary in Kerala, and his grandmother was also a central government employee. So here we are identifying the patient's internal resources. So at first, we are having his father and his brother, and they are living with the patient. So after that, this person is an IPS officer who is having his employment engagements. So there might be a paid caregiver. And apart from that, the grandparent of that patient was a chief secretary of in Kerala, which means he might be having a family pension support, and will be having reimbursements and all from the government itself. And his grandmother was also a central government employee, where there will be some government benefits from the grandparent itself, even after their demise. So this is identified because we have to identify their physically available social support system, and there are two persons and one caregiver. And apart from that, that family is financially stable because the patient's father is an IPS officer and has a good socioeconomic background uh, by considering his grandparents. So we identified their internal resources. Okay. So next we are going to explore what are the major psychosocial issues in palliative care. So we'll be dealing with some aspects in the upcoming slides too. So starting with the emotional distress, after getting diagnosed with an illness, a patient will have sadness, despair, and helplessness, and anxiety and depression, fear of pain, and even after proper pain management, they might be having fear of what to say, getting the pain back. So they might fear the suffering, and they might be having a fear of death. They might die. Oh, I'm going to die soon. So this kind of anxiety and depression will be there, and loss of autonomy. We as an individual will have an autonomic power within ourselves for decision making, for doing our basic daily living activities. But after getting diagnosed with an illness, this won't be the same. In some cases we have to depend our caregivers, and in some cases we there won't be any caregivers, where the patient will be emotionally distressed and will feel a kind of loss of autonomy and helplessness. So these aspects are included in the psychosocial aspects of a patient. And body image disturbances, especially after getting amputated and all. Otherwise, if a patient is getting paralyzed or getting bedbound and he is not able to walk, he has legs, but he is unable to walk. So he is getting wheelchair bound or bed bound patient. So this kind of loss of function is also affecting a patient. And the next one is role changes. We all have our own specific roles in our community and in our family and in our personal life. See, if I'm considering myself, I'm a son, I'm a brother, I'm a friend, I'm a social worker, and I'm a trainer and all. So if I'm getting diagnosed with an illness, there might be some fluctuations in my social or professional roles. So this role changes is affecting a patient's life. Especially, we are considering this as a psychosocial aspect of a patient. For example, if a son who is 30-year-old is getting uh, bedbound, or he got into an accident and he lost his ability to walk, and he's getting bedbound. So his father is 78 years old, and his mother got expired, and he has no siblings. So that son had a social role of a son to take care of his father. But unfortunately, he got diagnosed with paraplegia, hemiplegia, anything. And he's losing his proper mobility. So he has to depend, in some cases, he has to depend on his father, who is, say, 78 years old, who will be having frailty issues and other health related issues. So this kind of dependence will make the patient to have an idea or the patient will be thinking about this loss of role change, or loss of social role. As a son, he might be thinking like, I have to take care of my father, but unfortunately, I got into this situation, and I'm unable to do my social role. So he's losing his social role, which means altered roles in family and society. This aspect is also a psychosocial aspect of a patient. The next one is social isolation. After getting diagnosed with an illness, many of our patients are isolating themselves. In some scenarios, our community itself is excluding them from social interaction. One of our teams has faced a scenario where a patient is getting excluded, and when we went there and inquired about their current situation, their neighbors were saying, uh, the patient is diagnosed with CA, and the neighbors were saying they might get cancer from the patient. So this kind of stereotypical ideas or stigmas still exist in our community and society. So due to this, the patient might isolate themselves, or will get socially excluded from the community. And this is also a major psychosocial issue of a patient. Next one is caregiver burden. We discussed about a patient scenario where his father is 70, 80 years old and having frailty issues as well as other health related concerns. So in this scenario, the caregiver is having a lot of limitations, physical limitations and psychological limitations in providing care to his son. So in this scenario, the patient has to depend upon the caregiver regarding his basic needs. So the caregiver will have a lot of stress factors from the from the patient, as well as from his health concerns and frailty issues and all. So this kind of caregiver burden is also a psychosocial aspect of a patient, because it is directly affecting a patient's care. So the caregiver burden can be emotional, physical, or financial strain on the family members. So the caregiver might get strained or financially exhausted due to the medical expenses of a patient. So this is also a caregiver burden faced by the family of a patient. And the next one is financial hardships. We all know it is not easy to afford proper treatment or care in India. Compared to the Western countries, in India, we are having less expenses, but our socio-economic aspects is different from the Western countries. So in our aspects, for affording higher medical interventions or treatments are not easy for a commoner, especially procedures like ECMO, or if the patient is getting intubated for a long period. And these scenarios is not easily affordable for a patient, and especially their family members. So this kind of financial hardships, especially treatment expenses, and in some cases, the caregivers might get unemployed. They might lose their employment due to their caregiving responsibilities. So this is also a psychosocial aspect of a patient's life. The next one is existential and spiritual distress. We explored this one. In some cases, after getting diagnosed with an illness, some of our patients will have a lot of existential crisis, or they might be struggling to cope up with their current situation. And they might be having a spiritual distress, saying that, oh, it's because I was a sinner, I got punished with this kind of illness. I deserve to be punished. And I got diagnosed with this illness because of uh, the God's decision on punishing me upon my deeds. So all these spiritual and existential aspects are also considered under the psychosocial aspects of person. Is the drilling sound makes a disturbance here? It's from here. That's why I asked. Anyone? No. I hope no.
No, sir.
Okay. Okay. Let's continue. So fear of being a burden, especially in some cases. Just think about a person who has to depend upon another family member for financial expenses. So in that case itself, they might be having some fear of being a burden. Especially they are capable, they are potential enough to earn for themselves, but in some cases they might be unemployed, and they have to depend upon their family member. In that cases or that scenarios itself, that person is facing fear of being a burden. So now we come into the aspects of a patient's life where they are losing their power of decision making, power of doing basic needs for themselves, or power of taking care of the family, and getting dependent upon their family members regarding their financial expenses. So this concern about causing strain to family is also a psychosocial issue faced by a patient. Especially in some cases, the patients might be refusing to receive treatment after thinking about the medical expenses regarding their medical interventions. So we have to consider this under the psychosocial issues of a patient. And the next one is grief and anticipatory. Grief, not only related to a person's or a beloved one's demise, but also related to a loss of something which is beloved for us, especially in cases like, for me, health is a primary concern for me, mental health and physical health also. So if I'm losing my good health and I'm getting ill, I'm losing one of my primary concerns about my life. So that kind of loss also makes a kind of grief in the patient. The patient is losing something beloved for them, which means health. It can be anything. Health, person, it can be economical aspects, or it can be mental health well-being, it can be unaddressed spiritual needs, it can be anything. So loss of these aspects will generate a grief within the patient, can be in the family also, and also related to the beloved one's departure. Yes. We have to understand what somatization in palliative care is. So first we have to understand what somatization is, because we have explored the concept of total pain proposed by Dame Cecily Saunders. Why we are considering this total pain concept? We can address the pain through proper medications or physical interventions and all. Why we are considering the socio-economical, spiritual, and psychological aspects into pain? So if we are losing a lot of money regarding our medical expenses, we will be psychologically disturbed. We are losing our resources. And if we are lacking social interactions, we as social beings will be psychologically disturbed. And the same is applicable to the spiritual aspects. If we are having a lot of spiritual concerns, and we are not able to meet those needs, we will be psychologically disturbed. So all these aspects are intertwined with each other. So we can't separate from uh, that bond because each of them are interconnected. So starting with the somatization, these psychological aspects, these unaddressed psychological aspects can reflect as psychosomatic disorders or physical symptoms. Okay, so these physical symptoms, these psychological symptoms are reflected through our physical symptoms, especially in losing sleep, reducing appetite, or having pain, or feeling of some physical aspects. So it is experiencing psychological distress as a physical symptoms. So common in patients with unresolved emotional, social, or spiritual issues. Important to differentiate from disease progression. In some cases, we have to, not in some cases, we have to diagnose the patient through diagnostic procedures. Then only we will be able to identify whether this chief symptom is physical or psychological. So I have added a simple example here. Patient with a terminal cancer experiences constant chest pain, but diagnostic tests reveal no cardiac or cancer related cause. Upon psychosocial evaluation, it is found that the patient is overwhelmed with unresolved grief, which means the patient is not dead yet, but still he is having grief. Can be due to anything: loss of health, loss of a beloved one, and can be a feeling of abandonment can trigger this kind of guilt or grief. So, overwhelmed, unresolved grief, guilt, and anxiety over their family's future. The emotional distress is manifesting as physical pain, which is relieved through counseling, emotional support, and therapeutic interventions. Okay, is this concept clear for everyone? Somatization in palliative care, expression of psychological aspects into physical symptoms. Is this clear?
Yes, sir.
Okay, thank you, Richa Sharma. So the we should differentiate the disease progression and the psycho social issues, because we are including the somatization in psychosocial issues too. So it is mildly connected with the physical or medical aspects also. So before, what we say, concluding this as a somatization of a patient's psychological aspects, we have to have proper evidence in decision making. Especially we have to diagnose the patient, or we have to do physical or medical tests to ensure that the symptoms are not being a result of their disease progression. Okay, yes. So here we are going to explore physical aspects, which is connected with the psychosocial aspects of a patient. We all know about these aspects, so we are going a bit fast. Chronic pain, persistent discomfort can lead to depression, anxiety, helplessness, and can lead to existential distress and all. And breathlessness triggers fear of death, or losing control, panic attacks, or due to this limitation, they might socially withdraw. And fatigue and weakness limits their daily activities. They might feel fatigue and weakness, tired, feel tired. So they might be withdrawing themselves from their daily routines or activities itself. and reducing self-esteem. Like we all have our own self-esteem levels. So in some cases, in this scenarios itself, we might be having reduction in the self-confidence or self-esteem. Disfigurement and weight loss is also connected with the psychosocial aspects, because the person might be having a lot of coping up struggles, and won't be having self-image issues, and they will be struggling to cope up with their daily living. And this disfigurement and weight loss is also connected with the social interaction also, because we all, most of us are concerned with the social impression that we have in our community. And the next one is mobility restrictions. So it also leads to social isolation, frustration, loss of autonomy, and in some cases, we have to meet our daily needs. So in some cases, this mobility restrictions will affect our daily life directly. And sleep disturbances, which exacerbates irritability, emotional instability of a person, especially in enhancing the cognitive difficulties of an individual. And somatization, psychological issues manifesting as physical symptoms. Especially, I would like to underscore this mind body connection. Okay. Yes, we are going to explore the psychological aspects within the psychosocial aspects of care, starting with the depression, common but underdiagnosed. Symptoms include sadness, hopelessness, fatigue, withdrawal, and suicidal thoughts, anxiety, fear related to pain. We already discussed that, and fear of dying, fear of or anxiety related to their family or family functioning, financial concerns within the family, and may present as restlessness as symptom, and worry, panic attacks, mood swings, or social withdrawal from their common social interactions. And the next one is demoralization, where profound hopelessness is found, and helplessness is there, and loss of meaning of life. And different, it is different from the clinical depression, but also will have a lot of struggles, psychological and spiritual struggles within the patient itself. And the next one is delirium, acute confusion, agitation, hallucinations or delusions. They might be facing, especially in advanced illness or during hospitalization. Especially if they are admitted in an ICU, they might be having a kind of ICU psychosis uh, during their ICU admission. And the next one is fear of death and dying. We already explored this one. Existential anxiety, distress about separation. This distress about separation means can be anything. Separation from the good health, good family members, emotional separation, financial separation, and can be anything. And the fear of the unknown. The patient doesn't know about what the outcome is, or the patient might not be having an idea about their prognosis. So this kind of fear of death and dying will be there, and loss of control will be there regarding decision making, or regarding meeting their own basic needs. So the next one is loss of dignity and identity, feelings of worthlessness. They lost their feelings of uh, we all have a particular worth for ourselves. So after getting bed bound, we might lose all these kind of ideas about ourselves, our self esteem, confidence, and everything related to our self image. So this can lead to a feelings of worthlessness, or loss of self due to dependency, because we all have to depend upon our caregiver to meet our daily basic activities if we are getting uh, diagnosed with a limiting illness. So, and then post traumatic stress. So in some cases, some professionals won't be having a proper way of collusion breaking, or in some cases they might be the patient might be getting admitted into a critical care unit where there is no social interaction, only the beep beep sound. So all these may trigger the patient's psychological aspects and will be traumatic for the patient. So it can lead to post-traumatic stress, re-emergence of trauma in some patients, and especially those with prior traumatic experiences. So here, okay, 1 minute. Okay. So next we are going to explore the social aspects of care, starting with the social isolation. And the social isolation and or social exclusion can be related to their reduced mobility and due to stigma, abandonment from their family members, or it can lead to feelings of loneliness and despair. The next one is loss of social roles. We already discussed this one, where the 78-year-old father has to take care of his bedbound son. So loss of social roles is another psychosocial aspects. The next one is family conflict, especially on the disagreements over decision making, uh, financial management, or unresolved emotional issues can also intensify during their illness or disease progression. The next one is caregiver burden. We already explored this one. And the next one is social lack of social support. We explored internal uh, resources of a patient, but we did not explore the external support system. So friends, neighbors, extended family members, relatives can be a social external social support system of a patient, and in some cases they might be losing all this social support due to their illness. And the next one is stigma and discrimination. Illness related stigma, especially in the cases of HIV, cancer, or mental health disorders. And the next one is dependency and loss of privacy, especially needing help with personal care tasks can impact dignity, especially if we want to urinate. We have to, if we are a bedbound patient, either we have to depend upon the caregiver to use our bedpans, or we have to depend upon the diapers. So we are losing a major functioning of our life, so it affects our life. Okay, so this kind of things is also affecting us, and we have to become dependent upon the caregiver or family members. So this is making a loss in the privacy of a patient also. So the next one is housing and environmental barriers. So just imagine a patient a patient is getting wheelchair bound, but their house is not well modified enough to travel within the house itself. So we have to modify that house. Okay, there might be some barriers, there might be lacking there might be lacking slopes and all. We have to have proper house modifications in order to ensure the patient is having proper mobility within the house itself. Or in some cases, we might promote ventilation within the room which the patient is sleeping. And the next one is cultural and social norms. It might affect their communication, expression of needs, willingness to seek help. We all live in a society where there are a lot of cultural aspects and social norms. So, in some cases, after getting diagnosed with an illness, we might be having a lot of limitations in our way of communicating our needs, or willingness to ask help to our beloved ones and all. So the next one is community disengagements, reduced involvement in religious, social, neighborhood activities. Especially, we might be a person who used to go for badminton, or we might be a person who used to go for religious practices in a nearby church. So we, after getting diagnosed with an illness, we are losing all these aspects of our community engagement. So this is also affecting a patient's psychosocial aspects. Okay, the next one is economical aspects, loss of income, inability to work due to illness, or can be due to caregiving responsibilities, and leading to financial instability of a patient's family. So we have to think a medical expense of a patient is affecting the entire family in their socio-economic aspects. Okay, the next one is increased medical cost. We already explored this one. Expenses related to hospitalization, medications, investigations, and assistive devices. In some scenarios, palliative care itself is expensive in some part of our world. And the next one is travel and accessibility costs. So we have to make hospital visits. So we have to, in some cases, the patient won't be able to afford traveling in bus, because they might be having a lot of limited physical limitations and mobility restrictions. So they have to arrange uh, travel by auto, taxi, or ambulance, so which is more expensive than the bus fare. So this affects their financial stability. Transportation issues and cost for caregivers. In some scenarios, there won't be anyone to provide proper care for the patient. So the community or palliative care team or the patient itself might be appointing a paid caregiver there. So they have to invest a lot more financial resources within the for the caregiver. And the next one is unemployment of caregivers. We already discussed this one. Family members may leave the jobs to provide full-time care, and limited insurance coverage. In some cases, a lack of or insufficient insurance for palliative or long-term care is present in our medical system. And our medical insurances, most of our medical insurances are being rejected by stating some silly reasons. And the next one is lack of awareness, debt and asset liquidation, especially selling properties or taking loans in order to afford these medical expenses. The next one is lack of awareness of welfare schemes, especially in Kerala. We Pallium India are promoting cancer pensions in Kerala, but most of our Keralites are not aware about the pension that is available for Keralites, especially who got diagnosed with cancer, and they are not aware about the procedure. So all these, it is an example for this kind of lack of idea about the government schemes. So welfare schemes. So the next one is government support schemes, access to disability pensions, palliative care benefits, subsidized medicines, and social security supports. Like in some cases, the patient will be having a life-limiting illness, but won't be having a pension. But we can identify whether if the patient is having a space where they are eligible to get social support from the government. So the next one is role of social workers. We are the one who assesses the patient upon their psychosocial aspects of care, and we are also playing a major role in bridging the gap between the patient and the family, bridging the gap between the patient and the medical team. So we are the ones who facilitate all these services towards the family and the patient. So spiritual aspects, loss of meaning and purpose of life. Patient may struggle with understanding the purpose of suffering, why I am suffering due to this illness, or life as illness prognosis. Like Due to the illness progression, the patient will be having a lot of increase in the pain or symptoms. So they might be having a loss of meaning and purpose. Why I am living with this suffering? The next one is existential distress, where they are having a feelings of hopelessness. Why I am existing, and fear of death, questioning the value of life, experiencing a spiritual void, and all. Guilt and regret, unresolved past actions. They have done some bad deeds in their past, so they might be having this unresolved past reactions, actions. And the next one is strained relationships. The patient might be having a lot of strained relationships within the family itself. So this triggers a guilt and regret for the patient, and spiritual doubts may cause emotional turmoil. And fear of afterlife or death is also another concern about what happens after death. Mm, the next one is especially if beliefs are conflicted or unclear regarding the patient's spiritual, social, and psychological insights about their current situation. And the next one is religious spiritual conflict. We have already explored disconnection from faith practices, stating that, oh, I have lived as a good human, but still I got punished with this illness, and I'm not going to follow the religion anymore. So this kind of disconnection from the faith practices will be there. Physical limitations will be there. They won't be able to go to the nearby church, and all, to practice their faith and all. So physical limitations will be there, and it may prevent participating in prayer rituals or visiting places of worship like churches, temples, or mosques. The next one is isolation from spiritual community, being away from a spiritual support system, especially faith groups, clergy, or rituals. And the next one is a need for forgiveness and reconciliation. They have done a lot of bad deeds, or they might be having strained relationships. So they will have a need for forgiveness or reconciliation. So we have to channelize the available religious resources within the community towards the family and patient. The next one is culturally sensitive spiritual care, because we have to be highly sensitive, because even in religion, the religion itself is divided into subgroups. Okay, so we have to have a cultural sensitivity regarding the patient. We have to have a detailed assessment in order to understand what, in which the patient is in. The patient will be having a specific unique religious or social culture. So we have to provide interventions according to the patient's needs, not upon our availability or upon our interests. Then the next one is role of spiritual care providers. A lot of spiritual interventions can make a placebo effect for the patient, and especially in pain management itself. So, identifying this kind of religious available resources are also an important factor in providing religious or spiritual interventions towards the patient and family. Yes, here we are going to understand how we are going to address these psychosocial needs. uh, we are going to understand it as a procedure. Okay, we might be aware about all these things, but it has a standardized way of approach in providing proper way of interventions. So start with the need identification. Starts with the holistic assessment through interviews, tools, and team inputs. We are assessing the patient upon their physical, social, psychological, economical, and spiritual aspects, and we are taking inputs from the multidisciplinary team members. And after that, so after collecting all these informations, we will be able to identify what the patient really needs. And the next one is prioritization of needs, which should be prioritized first. So urgency based ranking should be there, especially in suicidal ideation, caregiver breakdown. In some cases, we have to address that need at that moment itself. In some cases, we will have time to mobilize the resources within the community, and in some cases, we won't be having a time limit, so we can take time as much as it is. So next one is care planning. After identifying a need, we prioritize those needs. So the next one is care planning, which should be addressed first and through which medium, which resources should be utilized. So especially in multidisciplinary team, the patient intervention plan should be made with smart goals. We will explore what smart goals really is. Okay. And the next one is emergency interventions. We are providing crisis intervention or management at that moment itself, uh, without waiting for any other procedure or any other aspects. If it's a crisis intervention, we are providing at that moment itself. Okay. Especially in the cases of abuse, housing, lack of basic amenities like housing, food, dress, shelter, and all. Okay. So next one is resource mapping and mobilization. This is applicable to any scenario. Okay. This psychosocial addressing procedure is applicable to any scenario, even in critical care unit. Okay. So resource mapping and mobilization identify internal and external resources like NGOs, schemes, volunteers, or students, or multidisciplinary team members itself, or can be external departments or other institutions from the community itself. So identifying this is also a major thing in the procedure when we are addressing or when we are making a proper intervention plan for the patient. So the next one is resource allocation. As you can see, it's not equal distribution. Okay, we should divide the resources on equity, like what do they deserve, do they deserve this, or how much they deserve it, and how much they deserve it to make the need satisfied. Okay, so equitable distribution should be there, and equitable distribution based on need, availability, and sustainability. The next one is follow up and review. We have done all these aspects. We have provided crisis intervention. We have mapped our resources, and we have channelized all these resources into the patient and family. But we have to know whether they are utilizing it well or not. We have to understand this, because then only our holistic care becomes meaningful. So ongoing reassessment to update and modify the interventions. Especially, for example, if I am stating about the current scenario in Palliative India, we are providing food kit support to the patient. We are only providing for 6 months. Why? Within the 6 months, we have to rehabilitate that patient into their social, economical, and psychological functioning. If we couldn't rehabilitate that patient within 6 months, we will reassess the patient and will justify to the team members that this patient is still needy and still worthy enough to receive this food kit support. So that is all about follow up and review. Yes, we are going to understand what smart goal setting is. Starting with the yes. Yes is for specific. Clearly defined objectives connect patient to government disability pension. We should have a specific idea about what we are going to do. It should not be like yeah, I have government facilities or schemes to mobilize, or the patient can apply for government schemes. It's an umbrella form of plan, but We should have a specific intervention plan. That is why we are yes for specific, clearly defined objectives. The next one is measurable. The process should be a trackable one, which means the application should be submitted. In the first scenario, we are going to apply a disability pension for a patient. So next we are going to plan. So I am going to help this patient to apply this in 1 week. So that is a measurable, trackable progress. And the next one is achievable. We should set realistic goals and targets within the available resources. We should have an awareness about the available resources for us. Then only we will be able to understand what type of intervention should be planned for the patient. So it should be achievable. If we are having a resources where we are only able to mobilize 1 lakh rupees, we should not be planning for mobilizing 1 crore rupees, because we are only having a resource where we will be able to mobilize the 1 lakh rupees for the patient. That is why we are saying it should be achievable. And the next one is relevant, aligned with the patient's current needs and priorities. We have identified the needs of the patient. The next we have done is prioritizing those needs. So upon the urgency of those needs, we are identifying the needs upon its priority. So the next one is relevant smart goal setting. It should be, when we are setting a goal, it should be relevant, and when we are setting a goal, it should be aligned with the priority of the patient's needs. Okay, the next one is time bound. In some cases, we have to set at certain timeline, then only we will be able to achieve that specific needs. The patient will be having an emergency need. If the patient needs, if the patient is having a suicidal ideation and is having tendencies to attempt a suicide, so we addressed or we identified this issue. Okay, so after this, we have to provide immediate intervention. We should not wait for the what we say, we should not wait for our comfortable time. We might be having a plan where we plan to meet 7 patients per day, but if we are spending more time for this patient regarding this crisis intervention, especially in addressing their suicidal ideation, it might take a bit more time. So we should have an idea which should be prioritized, which need should be prioritized. We have identified that the need is crisis. The need comes under the crisis intervention, so we should be addressing that need upon that moment itself as soon as possible. Okay, so this is smart goal setting when we are making a treatment or intervention plan for a patient. Yes, here are some books and guidelines for your reference. I can't actually, no one can frame psychosocial interventions because it is a vast one. Psychosocial interventions are an umbrella term used to address this psychological, social, economical, and spiritual aspects of a patient's life, which can be anything. Even lacking a light bulb in a patient's room is also a psychosocial issue for a patient. So we can't frame psychosocial what comes under the psychosocial issues because it is a vast one. So you can refer these books to explore more about the psychosocial interventions and how it should be addressed and how it should be identified and all. Okay, so all these books and guidelines can be adapted into your practice, and I have already presented some points And I can confidently say that all these points are just outer layers of psychosocial care and management. So if you want to know more about this, kindly refer to these books. And if you want to adapt a standardized approach in psychosocial interventions, kindly go through the guidelines propagated by these reputed organizations. So that's all about the psychosocial interventions and psychosocial issues. So if you have any doubt, I have covered all these points in a bit fast because I know all these points has to be concluded within a time limit. So if you have any doubts, kindly ask. Okay. Any doubts in identifying a psychosocial need, prioritizing a psychosocial need, or resource mapping, internal resource mapping, external resource mapping, or genogram, or addressing these needs or providing interventions, role of social workers, involvement of multidisciplinary team members, and smart goal setting, anything. You can ask anything.
The participant, if you have any doubts, please ask. No doubts. Thank you, sir, for wonderful session. Their messaging.
Okay, thank you for your patient listening. I know if I'm on your side, I'll confidently say that the session was a bit fast because it's a lot more to cover. We can't say it in one session because psychosocial issues are a lot more than these 12 slides. Okay, so that's why I really wanted to spend some time asking questions or clarifying doubts. And I know there will be a lot of limitations in understanding the points I have expressed or presented here. So kindly ask if you have any doubts. And I will be sharing this PPT with the team members. So they will be sharing it with you. So you can refer to these books and guidelines or other aspects of psychosocial interventions. Thank you for the session. Thank you.
Thank you, sir. Thank you so much.
Yes, thank you all.
Yes, sir. We also.
Thank you all. Any doubts? No, right? Yes, fortunately, no doubt. Thank you all.
There is no doubts, I think.
Yes, yes.
Thank you, everyone. Thank you, sir.
Thank you all. Have a good day. Bye.
Thank you, sir. Dear participant, we can wrap it up for today. And there is 3 more sessions to go. You can leave now.